Good morning, Sydney.
Good morning.
So you remember to click the setting?
Let's do this again. Share sound. Okay. Just gonna stop and do it over. Okay.
Let's just go ahead and test it again. Yep, it's working. Okay, we're in good shape. Thanks for doing this.
No problem. I understand it can be a challenge for one person with the length of the training.
Yeah.
Yeah.
So one thing I forgot to mention was the instructions for the small group session. So I'm going to send that to you. Do you know how to upload a file to chat?
I have not done that before.
Okay.
Chat. Oh, I see. File. And then are you sharing it through Dropbox, OneDrive, Google Drive, Box, or SharePoint?
I'm just going to send it to you so you can pull it up from your desktop.
Okay.
But I think you need to wait until everyone's in the room before you put it in the chat, because if people sign in after you've uploaded it, they won't see it.
So all I have to do is click the file on my desktop and drag and drop it to the chat?
Yeah, that should work. I mean, I've never drag and dropped. I've always used the browse function, but I don't see why that wouldn't work.
Are you talking about the exercise?
Yes.
Okay. So you're saying if people have already, if she puts it in before people join, they won't be able to see it?
Right. It's something
Oh, okay.
odd about chat and Zoom. So if you put something into chat and then someone signs on after that, they won't see it.
Oh, well, that's weird. Okay.
Yeah, because I don't see on my computer a way for me to go to my desktop, pull the file.
I'm also testing it out to see if there's a way for me to do it.
Okay.
Okay, everything just went white on my end.
It's a rainy day.
I'm not sure what that means.
No, on rainy days, all the electronics work oddly and they're slow.
Yeah. Do we want to test the volume while we're trying to figure this out? I think Cindy is trying to figure it out. I'm trying to figure it out. Between the two of us, somebody will get it.
Okay. And actually, let me try to put it in. I see what you're saying. This is new. I'm going to go ahead and put it on Google Drive, and maybe that will, then should be able to access it from there, Sydney.
Okay, so my goal is to share it from my screen.
Well, we'll have to put it in the chat, because once they break out into groups, they won't be able to see that main chat anymore.
Okay.
Or your screen, rather. They won't even be able to see your screen. They'll only be able to see the screen of whoever is in their group.
Yeah, so I guess as long as I have access to the Google file.
Right, and I'm just trying to figure out how to get it in there. I'm
trying to go through OneDrive, but it's not. It's acting like it doesn't understand what I'm trying to do. Okay, let's see.
If I send it to you, Sydney, do you know how to put it in the drive?
I can put it in the drive, in our sepsis drive.
Okay. All right, I'm gonna send it to you because I haven't figured out how to put it in the drive.
Okay, I'm gonna have to stop sharing.
Okay, you should have it now.
Dropbox. Mhm. So Sydney is the one sharing her slides.
Yes, and she and I tested the videos a couple of times already, and
Oh, okay. All right.
today, I mean, in addition, you know, I did a dry run on Monday and then we tested them again today.
Okay, all right.
So
That's
far, so good. I'm not
so far
saying
so
it's,
good.
you know, I'm not trying not to jinx it, but it worked a few minutes ago.
Okay, all right.
How are you doing today, Timmy? I forgot to ask.
I'm good. How is everybody else doing?
A little nervous, but that's to be expected.
Yeah, I mean, it'll go very well. We've gotten positive feedback from the training already, so I think that will be good. I think today's training will be good as well. I've always thought that today's training will have more of the tools, more of the interactions that they want, so which will be great.
Hello, everyone.
Good morning, Michelle. Or rather, good afternoon.
I can relate. I don't know what day or time it is either. How's everyone doing? Hello, Temi and Pamela. Hi, Sydney, you're here today. How are you?
Good. Hi, Michelle.
Hi.
Okay, I am trying to figure this out.
Good morning.
Hello.
Hello, Ms. Rogers. We'll be starting shortly. It's good to see you back.
Yes, last week I was the first one, and again this week I'm the first.
Nothing like being early.
Okay, I tested it. It's there. So I'll just do it again when everyone is.
Wonderful. Thanks, Sydney.
Thanks, Sydney. I was just typing you a private message because I stepped away for a few more minutes to join in, and then we'll go ahead and get started.
No, that cup. The nurse put it there.
they felt it was important enough to put some information in a care alert so that anyone that encountered the patient could.
Please let's remember to mute our lines, please.
Right in front of them, because it's very, very important. You know, who the most important family member is to speak with and how to reach them.
So I think we're going to go ahead and start. I know people are going to continue to join in. I see the numbers continue to join in, but I don't want us to waste any time. That way we can spend all of our time on the training. So once again, welcome everyone to day 2 of the sepsis training. And I will hand things over to Dr. Phoenix.
Good morning, everyone. I'm Dr. Janet Phoenix. I'm a senior consultant with the Grant Group. I'm very pleased to be with you here today to conduct the training. Before we get started with the pretest, I'd like to introduce my colleagues. First of all, I'd like to introduce Orlean Grant, who's the ED of the Grant Group. And Michelle George, who worked with me to put the content for the training together. Michelle?
Hi, everyone. Nice to meet you. Thank you, Dr. Phoenix. Hi, everyone. Very excited to meet you. Thank you for joining us today. I'm Michelle George. I'm one of the consultants assisting with this project, and we're happy to have you this week.
Right. And I'll just say hello.
Depending on the EA
and welcome. And we're very excited to be here.
in context app into their product. You know,
And I'd also like to acknowledge Sydney Robinson, who's going to be advancing the slides for us today and who also helped with the presentation. Sydney, would you like to introduce yourself?
Hi, everybody. Good afternoon. We hope this training is extremely valuable to you and hope it answers all your questions. Thank you.
So thanks very much to the Primary Care Coalition for asking us to conduct the training. It's been an adventure. We've gotten some good feedback about day 1, and we're hoping that day 2 will be equally valuable. Today, we'd like to start the training with a pretest, which is going to come up in the form of a poll. And so if you could respond to the questions, and then at the end of the day, I will go over the answers, and you'll get an opportunity to see how you did. And there are 4 questions, so make sure you scroll down and answer all. So we'll give it about another 30 seconds to give everyone a chance to respond. I misspoke, there are actually 5 questions.
Dr. Phoenix, we are getting about 6 responses right now. Do you want to give it a little bit more time?
Sure.
are currently at 12 of 27 responses.
Okay, we can give it another minute. Where are we now in terms of the responses?
We have 18 of 28 responses, and we have leveled.
Okay, let's take another minute. Okay, I think we're going to stop now. Some folks may have just opted not to take the pretest. And as I said, at the end of the presentation, at the end of the day, we'll go over the questions and the answers, so you'll have a chance to see. So Sydney, can I ask you to kind of move us to the outline, please? So today, I'd like to we're going to spend a little bit of time recapping what happened during day one. But before we transition to a video that recaps some of the topics from day one, I'm going to talk about some of the recommendations that came out of a recent workshop that the Institute of Medicine held that really focused on better ways to improve sepsis recognition and treatment. After the video, we're going to talk about some of those models for early recognition, focusing more attention on the models that were really developed for use in the nursing home setting, a skilled nursing facility setting. And then we'll talk about how to incorporate sepsis prevention and early recognition into efforts you may be undertaking already that are focused on quality improvement or performance improvement. And then we'll talk about some of the barriers and some of the facilitators, and that will be the day. There is a small group exercise, as there was during day one, that I hope you'll find useful. And we have posted the small group exercise in the chat. Some of you may have also received it when you registered for today. So I'm just hoping you'll have access to that when it comes time for the small group exercise. And I'll make sure that we send the discussion questions through a message board to you in your small groups, just in case you don't have access and you're not able to download the small group exercise from the chat. So with that, Sydney, let's move forward.
You can get in on your Zoom?
On now.
Oh, you're on now?
Yeah.
Okay.
So the Institute of Medicine workshop really focused on some things that are applicable for those who are working in long-term care settings. So a focus on improving the role of family members and caregivers in early recognition of sepsis. So I know a lot of you are familiar with tools like Stop and Watch, for example. And tools like that can really, really be very useful and helpful in training family and caregivers about what sepsis is and how they can work with you to identify signs of sepsis that might emerge, that they might recognize in their loved ones when they're visiting your facilities. The other nugget that emerged from the workshop was that we've all really been very, very focused on infectious disease because of the pandemic. And the changes we've had to make in terms of stepping up, training about infection control and prevention may really yield some benefits down the road in terms of sepsis because we're more attuned to it, we're more careful. We've gone through a lot of protocols and procedures in terms of ensuring that people have access to PPE and that they know how to use it. So all of these things are going to be useful to us in terms of sepsis prevention, because interrupting that pathway from infection to full-blown infection, infection that's out of control, infection that's systemic, is what we need to do to really interrupt the pathway to sepsis altogether. So all of the things that we've been doing will be helpful. Some of those lessons we've learned too well during the pandemic will help us in terms of putting protocols into place that can help with sepsis. So the emphasis is really on early diagnosis, and I think there's been growing recognition over time that the community setting is really where early recognition needs to be happening. By the time someone gets to the emergency room or to an acute care facility, you don't want things to be so advanced that it really becomes difficult for them to address it in that setting. So quality improvement initiatives that focus specifically on sepsis, but that kind of marshal the folks in your institution who are responsible for that, your preventionist teams that you may have put together to improve infection control and prevention. That's where you need to begin in terms of re-examining what you're currently able to do and what you want to do in terms of recognizing sepsis earlier. Next slide, please. Okay, so here comes a 5-minute video. It's going to go through a lot of the information that we covered in day one. And I promise you that there's no mention of the Krebs cycle or ATP in this 5-minute video.
Every year, more than 1.7 million Americans develop sepsis, a life-threatening medical condition that arises when the body initiates a powerful immune response against an infection. Anyone can get sepsis, but 2/3 of all sepsis cases occur in people over 60. Sepsis kills more people in the United States than breast cancer, prostate cancer, and AIDS combined. Older adults, especially those with chronic health conditions like heart disease and various types of cancer, are more likely to succumb to sepsis. However, early recognition of sepsis symptoms can save lives and reduce the risk of long-term effects. Sepsis is caused by bacterial, viral, parasitic, or fungal microbial infections that trigger overwhelming inflammation and blood thickening. Normally, the body's immune system targets invading microbes with a tempered response. However, in sepsis, the body overreacts, triggering a cascade of chemical messengers that cause inflammation within blood vessel linings. When this happens, small blood clots form, first at the site of infection and then throughout the body. Widespread inflammation and blood clotting impede oxygen and nutrient delivery to tissues and organs, resulting in organ dysfunction. An infection may begin in an organ like the lungs or kidney, or be introduced through an open sore, surgical incision, or invasive medical device like a urinary catheter or feeding tube. Common symptoms of sepsis include fever, rapid heart rate, and rapid breathing. The organ affected by the infection often dictates the other signs and symptoms of sepsis. For example, if the lung is the primary site of infection, as in pneumonia, the person may experience fever coupled with shortness of breath, painful coughing, and discolored mucus. Not all infections develop into sepsis. However, progression from a localized infection to full-blown sepsis can occur within hours. Therefore, it is important to swiftly recognize the signs and symptoms of an infection that's out of control. When an older person becomes septic, fever may be absent. In fact, the opposite can occur with the development of a cold, clammy skin temperature known as hypothermia. Older patients are also more likely to exhibit sudden mental confusion or delirium as a major part of their presenting signs, along with fatigue, malaise, weakness, sudden shortness of breath, poor appetite, chills, dizziness, and low blood pressure. When these symptoms occur, coupled with an infection, it is time to seek immediate medical attention. Older adults may be resistant to urgent medical care, but timely medical treatment is imperative to increase survival, since for every hour delay in appropriate treatment, the risk of death increases by up to 8%. Sepsis becomes more dangerous with age, and treatment is more likely to involve hospitalization and admission to the intensive care unit, or ICU. 70% of sepsis hospitalizations are in adults 60 years and older. Older adults admitted to the ICU for sepsis are also generally sicker, require longer lengths of stay, and may experience significant long-term cognitive impairment and physical limitations. Among older adults who do survive sepsis, 76% are more likely to be discharged to a skilled nursing facility, unable to return home. To limit sepsis-causing infections, seniors, their loved ones, and caregivers should receive flu and pneumonia vaccinations and practice good hand washing and good personal hygiene. Wound dressing and nursing care should use sterile techniques whenever feasible. Sepsis is common, deadly, and costly. It affects older Americans in disproportionate numbers. Weakened immunity, recent surgery, skin ulcerations, and chronic diseases such as diabetes, cancer, autoimmune disorders, or malnutrition make seniors more vulnerable to sepsis. To help reduce sepsis deaths in seniors, practice preventative strategies that reduce the spread of germs. Know the signs of sepsis and seek early treatment. Together, we can save lives.
Next slide, please. So I think the take-home message here is that many of the residents have risk factors that may make them more likely to develop sepsis in the long-term care setting. So, it's important to recognize that older age or the presence of some kind of a chronic condition like cancer or something that might immunocompromise people, or diabetes or heart disease can make an infection more dangerous for those residents. I think it's also important to recognize that there's a little bit of a division in terms of your population. So those who are permanent residents may actually be a healthier group than those who are coming for skilled nursing services, because typically people who are coming in on the skilled nursing side have had some kind of a condition that's caused them to be hospitalized, and they're coming to you from the hospital. And some of those people are also coming having had sepsis, and having had sepsis is a strong risk factor for developing it again. So I want to talk a little bit about how the field is changing and has changed over time. And I mentioned part of that change is recognition that early signs of sepsis can be recognized in the community setting. They can be recognized in long-term care. And if we can recognize those signs earlier, then we may be able to prevent people from having to be transferred to an acute care facility, or at the very least, we can interrupt the pathway of their disease so that the sepsis is not so severe and they can be successfully treated. So the timeline really started with looking at the SIRS criteria, which looks at vital signs, temperature, blood pressure, respiration, and use those criteria with some cutoff points to really point the way or point out which people were experiencing the early signs of sepsis. And then about 8 years ago, there was kind of new attention paid to developing tools that would be more suitable for the community setting. Again, as I said, this evolution that occurred so that, you know, instead of waiting until people arrived in the emergency room to really try to educate those who were working with them prior to that so that sepsis could be recognized earlier. And so SOFA and QSOFA were developed, and these were tools that were a little more amenable to being used in the community setting. And QSOFA really required no labs. Next slide. And so then the Minnesota Hospital Association got together and came up with a tool that really used some very easy to remember criteria, the 100, 100, 100. And that was recommended for use in the long-term care setting, easy to remember mnemonics, an elevation of temperature, an elevation of pulse, and so this became a tool that could be used easily in the community setting, was recommended for use in the long-term setting. And then Interact published a care path for sepsis in 2017. All of these tools were made available in online format so that they were easily accessible. They could be downloaded in paper form and used in training sessions for people in community settings or in long-term care. Next slide, please. So a number of these tools have been compared by researchers to look at their sensitivity, their specificity for sepsis. So look at particularly SIRS, QSOFA, and the Minnesota Hospital Association criteria were compared by Sloan. All of these tools proved to be useful in predicting which patients had sepsis. Some are a little better than others in terms of sensitivity, some a little better in terms of specificity, but they all work to a certain extent. I think the take-home message, and I think the message that I want to convey to you, is that it's not necessarily the tool that you use, but it's selecting the tool that really is well suited to the level of personnel. So if you're training certified nursing assistants, for example, you might want to use something that's really very, very simple, easy to remember, something that, you know, that hones in on a very few criteria that are very similar to vital signs that might be measured by that level of personnel. But then some of these tools that are a bit more data-driven and that might require taking a look at laboratory studies like white blood cell count, for example, may be more suited to a higher level of training. So it's not necessarily the tool, but it's matching the tool to the level of personnel, matching the training to the level of personnel. That's what I think will get you the best bang for your buck in terms of putting together something that will really work in your facility. Because, you know, it could be a great tool, but if people don't use the tool because they find it cumbersome or inaccessible, or it's just too much trouble or interrupts their workflow, then you won't get the information that you need, and you won't be alerted early enough that there's been a significant change in a resident that warrants your attention. Next slide. So that was one issue with with using some of the tools, is particularly things like a Glasgow Coma Scale recommendation to use to assess mental status people found cumbersome. But they did make notes that they had noticed changes in mental status. They just could not really fathom, for the most part, the use of the Glasgow Coma Scale. So you may want to incorporate some other test for mental acuity, something that's easier to administer at the bedside. As I said, I would strongly recommend kind of taking a look at all of the tools. And one thing we're going to be doing for you after this training is over is providing you with a manual. It will have links that you can go to and examine all of these tools. It'll have some analysis, some recommendations in terms of what's the best fit for a tool in terms of level of personnel. And so you may want to customize some aspects of each of these tools that we'll be walking through today to really to fit the needs of your facility and to be a better fit for your personnel. Next slide. So as I said, graphics, Post-its, things that can be placed in the work site to remind people about recognizing early signs and symptoms is really the way to go. Some of these tools are going to be paper-based. It's entirely possible that you will want to devote some time and attention and thought to incorporating some of this into your electronic health record to make it really pretty seamless so that people don't have to think about it as much. But as I said, you know, it's not the tool, it's whether people will use the tool. Next slide. I'm going to skip this one, go on to the next. Okay, and we'll go on to the next. So as I said, you know, these tools have evolved over time. The SIRS gave away to SOFA and QSOFA in 2014. QSOFA stands for Quick Sequential Organ Failure Assessment. And there have been studies that have looked at this one, and it's a pretty good predictor of whether someone will go on to develop organ dysfunction in a number of different organs. That's kind of the definition of sepsis. Next slide. But this was really intended for use in the non-ICU setting, in non-emergent settings, in community settings. So it can be used in long-term care. Next slide, please. So again, the downside is the mental status assessment. People found cumbersome, but it does really focus on vital signs. It does not require labs to be able to implement this tool, and so it has some usefulness. And it's something that could be incorporated into bedside care. It's something that people who are interacting with residents on a regular basis, who are not necessarily your highest skill level staff, could be trained to use something like this. Next slide. Next slide, please. So again, I've mentioned some of the limitations, but an additional limitation for this one is that the lactate level was not included as part of this because the QSOFA was really designed to be a non-lab-based tool. But it turns out that one of the developments in terms of really trying to hone in on a single study that could be predictive of whether someone is experiencing sepsis, whether they might need to be transferred from a long-term care setting into an acute care setting, is the lactate level. It's actually very useful in terms of telling us what's going on at the microcellular level. When those blood clots start to form, when the circulation breaks down, when vital organs are not getting the oxygenation that they need, your lactate levels are going to rise. And so it's a useful marker. Next slide, please. So here's the Minnesota Hospital Association tool. And as I said, we're going to be providing you with links to all of this. It kind of combines the SIRS criteria that I mentioned. That was one of the earliest tools used to pinpoint early signs of sepsis, with the Minnesota Hospital kind of surviving sepsis 100 mnemonic. So you use both of those things, a temperature elevation above 100, pulse rate above 100, and blood pressure below 100 is a really easy thing to remember. And it's really easy to train people to implement this. So it's kind of a yes/no thing. If you get a yes, and you're seeing not only, the 100, 100, 100 criteria be met, but also that there's some signs of infection, then you're going to want to bump this up to a higher level. This is where the CNA or the LPN would want to call this resident's condition to the attention, perhaps of the resident registered nurse or an advanced practice nurse who may be available to talk it over. And this is where increased monitoring might be appropriate, to go back a little bit more frequently to check those vital signs again to see how things are changing. And then depending upon what happens, to quickly notify the provider. And it's at this point where, there may be a divergence in terms of what you feel comfortable doing in your facility. In some facilities, they have standing orders in place. And so at this point, once the sepsis criteria is triggered and there's signs of infection, and the condition seems to be on a downward trend, then fluid resuscitation might start. And in some facilities, there are standing orders for administration of broad spectrum antibiotics. Now, this is a judgment call, a protocol decision that's going to differ depending on what you're comfortable with, what your medical director is comfortable with. But I want to flag for you that in some places, they have put a plan in place that does not require a discussion ahead of time with whoever is the physician on call to begin to address sepsis if these screens are triggered, so that fluid resuscitation at a minimum could begin. Of course, that means you have to have somebody around who can place the line. There are a lot of things that have to be in place for this to happen, and some of those I mentioned in day one. But think about the fact that it can take time to get in touch with the physician on call. So part of planning for ramping up your sepsis protocols is having a discussion with your medical director about at what point can we act? Are there things we can do prior to having the discussion with you? Kind of take a look at the systems that you have in place. Next slide, please. So I've gone over this earlier part of the protocol all the way up to the point of notifying the provider. Next slide, please. And so at the point where you're having the discussion with the physician on call, then, these are some of the labs that may be ordered to really hone in on the site of infection, to confirm your suspicion that there's an infection, and to really begin to get some information about the resident's condition. And again, depending upon the presence or the absence of any directives that might be in place, you're going to go in one direction or another. And then if you have the ability to get stat labs in and they come back and it seems that things are on a downward trend, at that point, you may make a decision to transfer. Next slide, please. So again, the Minnesota Hospital Association tool was really designed for you. It was designed for use in the long-term setting, for skilled nursing homes to use, and it really has some utility. But I think what's important to recognize is that we're kind of still in a process of evolution in terms of knowing how well or how poorly some of these tools will function. This is something that's still being studied. The application of these tools in the nursing home setting is still being studied. We still don't have a lot of good information about how using these tools, how effective it is in terms of reducing mortality. There is some information that's available, though, about how effective they are in interrupting that pathway to severe sepsis, and potentially cutting down on the number of people who get into a cycle of having to be transferred back and forth from skilled nursing to acute care and then back again. And certainly the hospital facilities that you're working closely with are being measured in terms of how well they can prevent that readmission process. And they get dinged if the readmission process happens too frequently, or if they have to keep patients for a longer period of time because their sepsis is very severe. So they're motivated to work with you to help you to recognize this disease earlier. Next slide, please. So I'm going to start to move kind of fast. Next slide, please, because most of these tools really cover similar parameters. Next slide, please. And so, I don't feel as if we need to go through every single one in great detail. This is one that was developed by a quality improvement organization in the Midwest. Nevada and Utah were two of the states that were involved in developing this. But again, it uses a very similar care path for you in terms of leading you from vital signs that are alarming, signs of infection, through a process where you can have a discussion with higher skill level personnel about what to do for this resident. Recommends labs that be drawn and early treatment that you might want to implement, such as fluid resuscitation, administration of broad spectrum antibiotics. Next slide, please. So the process is the same. Next slide, please. And I think the challenge is really to match the tool for the setting and the appropriate tool for the appropriate level of personnel. Next slide, please. Next slide, please. So lastly, the Interact site is really a place where I think you will be spending some time. Those of you who are going to be re-examining how you're recognizing and treating early sepsis in your institutions will find the Interact site very useful. It's a whole suite of tools that addresses every step of the process, and you can use them in paper form. You can adapt elements of these potentially to be incorporated into your electronic health record, but they're very, very useful. And again, it's nice to have tools that were developed specifically for SNFs. Go ahead, please. Next slide. Next slide, please. So again, I think, the starting point for all of this is going to be something like Stop and Watch, because this is simple, it's easy to use. The bedside caregiver, the family member, and even people who are working in different parts of your institution, maybe on the rehabilitation side or in food service, they can all be trained using something like Stop and Watch. They can be that to help them understand what sepsis is and why it's important to recognize the signs earlier, and to encourage them and support them to alert you if they're seeing these signs. And that's the important thing, that encouragement, that support, that feedback. If someone brings something to your attention, that's all going to help to make this a systematic process, and to make sure that this happens across all staff, and that it happens early. Next slide, please. So we talked with folks in Nevada. This is the tool that the folks in Nevada developed. As I said, it's the same set of parameters that you'll find on the Minnesota Hospital Association tools, and also the same set of parameters that Interact is looking at. They gave us some really good suggestions because they were really focused specifically on skilled nursing facilities. One thing they said is that it's important to have a conversation with the medical director and make sure they're on board. If you want to make changes to how you're addressing sepsis now, you know, the medical director really has to be enthusiastic about whatever changes you want to make. And they, you know, so what I would encourage is really some kind of a systematic approach, assigning someone responsibility for examining your protocols, the ones that you have now, and then thinking about what changes you might want to make. But that, and then a group of folks who that point person works with to develop any new protocols that you might want to use, perhaps adapting bits and pieces of these tools that we've been working through. But that process has to involve your medical director, because without support from the medical director, none of this will happen. And without support from the medical director, you're going to reach a point where you'll hit a wall, especially if you're trying to institute standing orders or something that allows you to act a bit more quickly. You know, they have to be supportive of that process. Next slide, please. Next slide. Actually, let's just keep going again. Okay, so again, starting with vital signs, that's a common theme that's running through all of these screening tools, is that you're starting with vital signs, you're starting with the lowest trained personnel. You want to improve their ability to recognize these early signs of sepsis. Next slide. So we kind of took some of the tools and just put a tool comparison chart together. You know, things that are on the left-hand side of this chart are going to be things that a CNA or an LPN might be measuring. Things that are on the right-hand side are going to be things that your higher level skilled personnel, registered nurses, your nursing supervisor will probably be more able to apply. But we wanted to kind of put everything together so that you could take a look. Next slide, please. It starts with determining if there's an infection and recognizing that for some people, an infection may take a more aggressive course than for others. So your diabetics, your folks with cancer, people with immunocompromised, their infections need to be monitored more frequently and more aggressively than infections in someone who doesn't have those chronic diseases. Next slide. So you're going to want to use some kind of a systematic way of documenting changes in symptoms. And this is something that everybody needs to be familiar with and comfortable with. It could be in the electronic health record, it could be a paper tool, but whatever method you use or whatever set of methods you used, you know, everyone has to be clear and consistent with documenting the changes. Next slide. And then clear guidance about when to huddle, to have a conversation about a change that's been observed in a resident, and clear protocols about how this information gets communicated, perhaps to a higher trained person, your advanced practice nurse, or potentially the physician on call. Next slide. And so SBAR is really kind of the tool we use, next slide, to do that reporting. And there are lots of different tools, training tools that can be used to train people about how to organize the information that they're observing about the resident who's in front of them in a way that it can be systematically communicated. So this, you know, a concise statement of what the problem is, and some background information, an assessment of what you think is going on, and then a request for action. Next slide. So in the case of sepsis, it might be a report that the supervising nurse makes over the phone to the physician on call that a resident has triggered the screening for sepsis, whichever screening tool you're using. That describes what those symptoms are. And if there's an infection that's been documented, that information is included. If there are signs that one of the organ systems is failing, that information is included. any the vital signs or any other assessments that might have taken place, pulse ox, and then what it is that you think should happen. Next slide. So I like the ARC tools for SBAR. They're a little simpler. Some of the tools on the Interact site, for example, are very complex. If I were you, I would err on the side of simplicity. You know, the complex tools are nice in terms of all of the details that they record. But if they're so complex that nobody uses them, then you don't get the information that you need. Next slide. Let's keep going. And all of these things we're going to make available to you. Next slide. We're going to provide you with a Train the Trainer manual, and you'll have access to all of these materials. Next slide. Next slide. One more. So despite all your best efforts, there are going to be times when you need to transfer someone. You know, the situation is going to be changing rapidly, despite what you have done in terms of fluid resuscitation, more frequent monitoring. Things are not improving. You may have done a stat lab, and the labs are not looking good. And so there are going to be times when you're going to need to transfer it. Next slide. And so Interact has tools that you can use to document the information about what has happened in your facility that can accompany the resident as they're being transported to acute care. Next slide, please. And so those are useful things. But regardless of whether you use the Interact tools or you use something that you already have in-house for transfer, it's just important to recognize that, you know, things fall through the cracks. So you want to make sure that whoever is receiving the resident at the emergency room knows who at your facility they can contact to get any information that may be unclear or that may not have been communicated or arrived with the resident. And so that information needs to be documented. And then it's also important that family members be notified so that they're not surprised and so that they're informed about what's going on with their loved one. Next slide, please. So as I said, making sure that all of the symptoms, the treatment, the timing, when things started to emerge, the lab results, if you've ordered labs, that everything is communicated and that there's a clear point of contact for your facility, but also for the lab that you're using, so that if the emergency room needs to contact the lab to get some clarity, that they can do that. Next slide. So we're going to do our small group exercise now. And so I wanted to remind you about the case study that we talked about during day one. Deborah, a 73-year-old woman, has been feeling weak and dizzy. She has fever, and she has not really been eating well. She's really been having symptoms over the last couple of days in terms of decrease in appetite. She is a full code. She has hypertension and heart disease. She has been a smoker, a heavy smoker. And so there was a lot of discussion in your small groups about how to respond to Deborah. Next slide, please. So labs were ordered. These were the labs: lactate, blood cultures, 2 blood cultures, a urinalysis, electrolytes, a BUN, creatinine, and clotting studies. Next slide. And Deborah was started on a fluid bolus and on broad spectrum antibiotics, and was stepped up protocol for monitoring her vital signs. Next slide. But despite that, things continued to decline for Deborah, and she remained confused. Her pulse is getting worse. Blood pressure is a little lower. and she's having trouble keeping up in terms of her respiration. Next slide, please. So the lab values came back, and her lactate is elevated. White blood cell count is abnormal. Really, all of the labs are abnormal for her. And so what I'd like you to do is to spend some time in your small group thinking about what happened to Deborah, but thinking about it in terms of how your institution could plan to respond more rapidly the next time a resident presents with symptoms that are similar to what Deborah was experiencing, because a couple of days went by with her really being, not feeling well, not eating properly, and that's a long time for someone who has a chronic disease that we know might predispose them to develop sepsis. Next slide, please. I think you skipped one. I think there might have been. Okay, so you should have the discussion questions in the chat. I believe the day 2 exercise was also sent to you by email when you registered. And again, the goal is to talk about how Deborah's experience could really be an opportunity for your institution to examine what you're currently doing, to think about ways that perhaps her symptoms could have been recognized earlier, and what kinds of systems might you recommend, and who might be involved in revamping the systems that you already have in place to help you to identify residents like Deborah a bit earlier in the course of their disease. Because as it turns out, Deborah's labs were so out of kilter that she needed to be transferred to acute care, but she expired in the ambulance on the way. So we'll take 20 minutes to do the small group exercise. Please stay in your small groups. You're going to be randomized to a small group, and you should be able to download the exercise from the chat. And if not, hopefully someone in your small group has received it by email because they pre-registered before today. So I'll see you when we come back together.
Okay.
septic. Some doctors are not comfortable to leave any standing order.
True.
Okay, we are back.
Oh,
Welcome back, everyone.
oh, that's
So I'm
awesome.
really interested to hear how the discussions went in your small groups. So each small group should have someone who volunteered to report back.
Jackie, you want to report back on our group?
Well, okay. Hi, guys. So the one thing that did come out, and hi, Janet. Thank you for everything you're doing for all of us. We're learning more things maybe than we really were paying attention to. The question 1 through 5, we kind of went through them. For us as the group, a couple of things popped up, and we started talking about with the COVID being with us for the past year, and I guess we're going on almost a month. You know, some of the buildings were bringing in agency. Staffing was an issue. So even though we're looking at what can we do properly so we can catch the sepsis early, you know, the particular group I was with, we were talking about the type of nurses you have on board, and they're so busy doing other things. Are people, even the aides, are people paying attention to what they're properly doing? The COVID screens are something we do, you know, for shifts, and the aides are taking vitals and putting them in. And are they really paying attention to the vitals? And of course, you know, if you are using PCC, there are some, it turns red and colors change if the things aren't correct. But again, I think we're looking at the busyness of the nurses. Unfortunately, it came up. And with regards to, you know, I'll go take a look at the patient later, which could delay some things going on. The other thing that came up was the doctors that are on board, some of them not being comfortable with standing orders, because maybe the nurses aren't familiar to them. You know, if it's you and me, Janet, and a few other of us that have been with the doctor for 10 years, that's one thing, right? But, you know, for other nurses or maybe agency nurse now in the building, doctor may not be comfortable with the standing order. So again, we had the 5 questions to look at, and we're talking about QA, but these are some areas that the buildings, many buildings, I believe, are struggling with, just the proper staffing ratios and that they're all talking to each other, but not necessarily putting a good note down. So if you didn't write it, it didn't happen type of thing. So I think those are some of the barriers right now that are going on. I think out of my group, is that kind of where we were at? So aside from all the great tools and stuff, and if you have agency and do they know how to use the tools we're using? And do they know even how to get into PCC? So we had a few discussions on that. So we didn't get into really the question 1 through 5 for the QA. They were more concerned about the staffing ratios, and that's going to take another couple of years to get that straightened out. So
Okay. So even given your concerns about staffing, do you think you might be able to get to a level where perhaps some training, regular training on stop and watch could be implemented? You know, kind of, you know, starting with modest, achievable goals rather than jumping into the standing order question.
So I think too, where they popped up, stop and watch. We were talking about that stop and watch tool on an incident that we had happen over here not long ago, because a lot of buildings are going paperless, not mine, unfortunately, but because of the paperless, that some people have gone away from using the stop and watch tool. Does that sound funny? So it is a great tool. And it helps the aide then to give to the nurse, and therefore shows the communication path. But perhaps something electronic would need to be put in play too. Again, I guess with my group, a lot of the group did not have paper anymore. So, so that came up. So that's a good one. Yes, all these tools are wonderful. I guess it's just as long as everybody's using them and people are communicating and writing things down. Yeah.
Okay. Can we hear from another group?
Hi, this is Pat. I'm speaking from out in the hallway, but I'll do my best. So we had some of those same answers, stop and watch, making sure there's an advance directive. And someone also mentioned that PCC, most systems, PCC sets up an alert that, you know, there's an increased temperature or the vital signs are off. It's usually inputted by the GNA. In some places, it's inputted by the unit secretary. But the frontline people, we're trying to involve everybody to alert people right away. And oftentimes it's not the nurse. Oftentimes it's these other ancillary people. So we had some of those same things, except advanced directives was something that we came up with as well to make sure that that's in place.
Okay. So I'll kind of ask the same question then, you know, if it's, you know, folks at, you know, kind of at the unit level, not necessarily highly trained people who might really be the ones to notice these signs. Did you get to the point in your group where you were thinking about a workaround or something that might be appropriate in terms of training or something directed at staff at that level to encourage them to report things they might be seeing?
Yes, education was one of the things we talked about, trying to communicate with everybody, including, I know on my unit, oftentimes even the housekeepers notice a difference in the patient. They might not necessarily know the specific vital signs, but you can involve all of the ancillary people, all of the ancillary services to try and give you a heads up that something's going on with the patient.
Great. So I'm not sure how many groups we had, but I think we may not have heard from all of them.
Dr. Phoenix, we had 4 groups.
4 groups, okay. So others, can we hear from others? Excuse me, what would you like to add to this conversation?
This is Shannon. My group, we kind of just looked at the questions and talked about training. Relias is a really good resort because, you know, it's kind of forced your hand, but also at the center level, just making sure that we provide training and education and just repeating it over and over and over again to all different departments, not just nursing, but also, you know, anyone that's involved with the resident or a resident of any kind on a daily basis. They need to also be aware of what to look for. If we had to present, of course, we think there would be some kickback maybe from pharmacy based on just that it's just kind of like a blanket standing orders. Sometimes I know our pharmacist isn't always keen on standing orders, but I think at the clinical level, I think that sometimes standing orders are just a blanket and they just cover everything and they don't really force them to look at something specific. So I think that's just really important that we might have a little kickback from that we really have to focus on training and re-education. I think we also said that when it comes to how are we going to counter any objections we might get from any of our proposals is that we're going to use hard data. We're going to have to go back and look at the people that we sent out and what was the causative factors or what was leading up to them going out and having that hard data available, you know, and presenting that. And then some of the barriers we talked about were basically that the clinical staff just might feel like it's more work, more assessments, more things to learn when they're already overwhelmed and staffing issues at hand as well. So.
Great report back. So I think we have one more group left.
On our group, we talk about proper in-service education for the staff so they can identify the data and collect them accurately. We talk about involving everybody, physician, nurses, pharmacists, and everybody. We were kind of split about the standing orders. You know, for example, IV fluid, if you don't hear from the doctor, how are you gonna, what rate, how many liters you're gonna initiate or you're gonna administer. The antibiotic order was the same thing. We were kind of divided. We didn't know if it was a good idea to just put it as a standing order or to reach to the doctor and see exactly what the doctor will propose than to just put it as a standing order. And as a barrier, or the barrier for implementing the standing order was maybe the doctor might not feel comfortable to just let you use his name, because at the end of the day, you have to put an order. And even if the doctor is on call and you cannot reach the doctor might not be comfortable to just use his name and just put an order that he's not aware of, or he's not, he would have to do something different.
Okay. Okay, well, it sounds like the discussion in the small groups was great. I wish I had been in one of them, but I had folks who were in various groups who are going to be reporting back to me, and the information will be useful because, you know, as we're putting the manual together for you to use after this training is over, you know, we want to be able to address some of the things that you flagged. That you might see as potential barriers, and try to address that in some way, even if it's only by talking about how other skilled nursing facilities in other parts of the country have confronted some of these same issues, so that you can think about that as you take this information home with you. So thank you. Thank you very much. And I would also encourage you to, if you think of something after today's training that you think might be useful or that you want us to address or to incorporate into the training manual and into the materials that we're putting together for you, please feel free to reach out to folks at PCC. They will pass the information along to us, and it will help us as we put the manual together. So with that, Sydney, I'm going to ask you if you could share your screen again, and please remember to check that box for the sound, and we'll start again. Okay, so this is the part of the presentation where I want to talk about some quality improvement, performance improvement initiatives that other institutions have instituted in different parts of the country that you may want to think about as you're re-examining what you're doing in your institution. Next slide, please. So one thing that I mentioned earlier, and again, this is something that it may not be a tomorrow fix, but it might be something that you want to plan for down the road, is using the electronic health record to include some of these prompts so that the process becomes a little more automatic, and so that you don't necessarily have to rely on discussion at time of shift change, or rely on someone, you know, filling out a paper tool, so that, you know, the information really prompts an action by someone who is who receives some kind of an alert through your electronic health record. And it could also be that this is a way of identifying some folks who may be at higher risk for developing sepsis, so that, you know, when new people come in and they're caring for someone who they may not have seen before, there's something to indicate for them that, you know, because this person has a chronic disease, or because this person had sepsis in the past, we need to be a bit more concerned if we see signs of an infection or if we see a change in their vital signs. Next slide, please. So one system really worked very hard to implement this, and this was a consortium of institutions. So it included some SNFs, it included some acute care hospitals, and a couple of long-term care hospitals, and they worked together to make a change in using this electronic health record to support their sepsis decision-making. But this, of course, required an investment of funds. But they were able to do this because they had received a CMS innovation grant, and so they had some upfront dollars they could use, and they chose sepsis as what they wanted to concentrate on initially. Next slide, please. So they were able to institute kind of a web-based algorithm that would prompt an alert if there were, you know, if certain triggers happen. So if there were certain changes in vital signs and can't say that word today, oxygenation, then it would trigger an alert, and the alert would go to a registered nurse or an advanced practice nurse who had to take some action. Basically, there had to be a reevaluation of the person in order for the alert to turn off. So this became a good tool for them to use, and again, this was implemented. Changes in electronic health record, of course, are not inexpensive things to do, but because they were able to get this quality improvement grant, they had the funds to use to make this investment. Next slide, please. And they were defining the intervention as including a fluid bolus, broad spectrum antibiotics, a collection of blood cultures, and collection of a lactic acid level. Next slide. So this is just kind of an algorithm that shows you how it all worked. Again, the alert would fire, the alert would go to a physician assistant as well as the registered nurse, and it would trigger certain actions to be taken. You know, the initial action, of course, would be a reevaluation of the information that triggered the alert. But then if it was confirmed, certain things would happen. The labs would get drawn, fluid bolus would get started, antibiotics would be administered, and then a reassessment would occur at regular intervals. Next slide, please. Another option, and this one actually is much less expensive to implement, is using simulations. So what you may want to think about doing, especially for training staff, and one thing that was pointed out to me during the last training session is that there's a lot of turnover. And so whatever training protocols and you put into place, you know, you have to take into account that you're going to have to retrain often enough that new staff are going to be alerted to how to recognize sepsis early, just like the staff who are more long-term are trained. And simulations can really be a great way of doing this. So, you know, taking a case study example, like the one we've been talking about today, and really creating some opportunities for people to practice doing the things that they ordinarily do, but with a simulation involving, you know, the kinds of symptoms that would lead us to believe that someone may be in the early stages of sepsis. And training people to be able to tell the right person about this information and to do so in a timely manner. So that's what you want to incorporate into your training exercises. So Houston really developed a training program and focused on nurses really being their early recognition and response system. And they worked to find a tool that would be acceptable for people to use. And so they used one that was based on the SIRS criteria, and they embedded a scale in there so that it would kind of give you a numerical score to make it really, really easy to interpret the results. And then a mental status was assessed using kind of a yes/no algorithm. Is the patient alert and oriented, or do they seem confused, or do they seem different from their baseline? Because of course, you know, you're working with a lot of people who may have some baseline cognitive deficits. And so it's important to be able to notice a change in those folks, which might be different than the change you would notice in someone who's ordinarily pretty alert and oriented. Next slide. So this system worked pretty well for them. Next slide. It started off as a paper system, but then they were able to transition it into the electronic health record so that things would kind of auto-populate. So as a new set of vitals were obtained and they went in, the computer would compare the new vitals with the earlier vitals and really kind of, you know, take a lot of the work in terms of interpreting the results and trying to make a decision about whether this is important enough to report it up the chain to somebody out of the hands of the individual and into the hands of the computer algorithm. So eventually we won't have to think about anything at all as these computers get smarter. Next slide, please. And a critical part of this was that they did have kind of buy-in from medical administration that some things could be done based on the algorithm. And then there would be a conversation after perhaps that fluid bolus was administered about what the next step should be. Next slide. Next slide, please. So this program was evaluated. It really, there were statistically significant improvements in early recognition of sepsis and in the outcomes for people who had sepsis. Next slide. And of course, a big concern was the cost effectiveness of this. As I said, this involved a number of institutions, so a lot of zeros behind these dollar signs. But again, the cost savings was significant. They were able to shorten stays. That was really a huge driver of the cost savings. People, when they were hospitalized for sepsis, it was for shorter stays. And so they were able to show a lot of savings on the CMS side. And they worked out a system where personnel from the acute care side worked with skilled nursing facilities who were transferring their patients to those acute care facilities. And they did the training. It was cost effective for them to provide the training so that the SNFs didn't have to invest in that. But the acute care hospitals reaped the savings on the backside. So it was still cost effective for them to do that. Again, this is ambitious, these multi-center kinds of initiatives. I would encourage you to, start with something that you can get your arms around, that just involve your own facility. But down the road as a community, you may want to begin having some conversations about, is there, something that we can do as a group of institutions? Or if you have a relationship already with certain hospital systems, to begin having conversations with their sepsis coordinators about some things that perhaps you can cooperate and do together. Next slide. So I mentioned the, the numbers improved in terms of the admission back to acute care. So this readmission cycle that I talked about decreased significantly. And then of course, this represented savings to CMS. Next slide. So I think the take-home message from all of these programs, these quality improvement initiatives that have been reported in the literature, is that sometimes you can prevent an admission. So you may be able, if you intervene early enough, recognize the signs early enough, to be able to stabilize people so that they don't have to leave their skilled nursing facility. And for some people, this is really a benefit. Because some people don't do well in an acute care setting, and it might be necessary if they're sick enough to do it. But if you can address their concerns, their medical concerns, in the setting where they're comfortable and do it early enough, then maybe they don't have to be transferred. Next slide. Next slide, please. So again, it all starts with infection prevention. And, this is something that you think about every day, many times during the day. And there are people who really have, that's their sole responsibility, is to really think about infection control and prevention in your SNF. And so I would strongly recommend starting with the folks who have that responsibility at your institution to be thinking about, okay, infection prevention in terms of recognizing infections early, and also how can we interrupt that pathway to sepsis at the same time that we're addressing infection prevention and control in our institution. Next slide. Because, you know, there are going to be obstacles, there are going to be barriers. One of them is, you know, this issue that you've talked about in some of the small groups about a reluctance to prescribe antibiotics, especially a reluctance to have a standing order that would trigger prescribing antibiotics either, you know, in concurrent with a conversation with the on-call physician or potentially prior to the conversation with the on-call physician, because everybody's worried about overuse of antibiotics. You don't necessarily want to make that, you know, the first thing you do. Next slide, please. But at the same time, you know, it's important to recognize that early treatment has been shown to be effective at preventing death. And so again, I wanted to show this slide again. I showed it during the last training session. The gray bars, of course, represent time to administration of antibiotics. And the black bars are survival. And so you can see that, you know, if you can get antibiotics in within the first hour, that's the first 2 bars, then, you know, the survival fraction really increases. And the longer you wait, the more likely it is that that person will have an outcome that we would like to avoid. Next slide. Okay, so barriers and facilitators, we've covered a lot of this already. Next slide. Next slide. So I just want to kind of bring back up that this is something that not only are you thinking about, not only is Montgomery County thinking about, but really everyone is thinking about ways to improve quality and thinking about ways to use this information that we collect regularly from residents to trigger our concern and to be able to alert us to dangerous changes that might be going on with someone who's under our care. And regardless of what set of criteria you use, and there are lots of different ones, that, you know, they almost all come back down to this set of vital signs and how you interpret the information about these vital signs, and someone kind of really being able to pick up on trends. You know, it's not a matter of just taking the vital sign, writing the number down, and then, you know, the shift changes and someone else comes in and takes the vital signs and writes the information down or enters it into an electronic record. And nobody is really kind of, you know, looking at the trends. Next slide, please. But in addition, you know, infections are going to happen, but it's how early do we recognize the signs of infection, and how easy is it for us to pinpoint a particular organ system that might be involved? Do we have someone who has an indwelling urinary catheter? If so, then we need to really be on heightened alert that that person could develop a UTI. And that could be one of the things that, you know, puts them on the road to sepsis. Next slide. Next slide, please. Similarly with respiratory infections. Next slide. Next slide, please. Or with GI infections. So pneumonia, urinary tract infections, GI infections, and skin and soft tissue. Those are kind of the top 4 groupings. Really being able to catch those early before the infection becomes disseminated throughout the body is our goal in terms of sepsis prevention and sepsis early recognition. So these Interact tools, as I said before, are going to be very useful for you. You have an entire suite of things that will assist you not only with recognizing signs of sepsis early, but with really recognizing signs of the top kinds of infections that we know are associated with sepsis. Next slide. But the key is to pick a tool or to develop a set of tools for yourself, for your institution, that are going to be easy for people to use, not overly burdensome. And that may mean that you need to customize something that really works well for you, where you pick bits and pieces of things, try it out, see how it works, get some feedback from your staff. Are they comfortable with it? Tweak it a bit, and then it becomes a protocol. Next slide. So the important thing is that there are roles for everybody. Anyone who's in the institution can play a role, but you have to think through carefully what's the appropriate role for each of these to play. Next slide. So just to kind of summarize the recommendations, a team approach, and that team needs to include your infection preventionist. It also needs to include the medical director, so that, you know, at a minimum, those folks are intimately involved in making any changes in your sepsis protocols. You may want to collect some data to guide what you're doing. Maybe things are going well. It could be that, you know, your staff are well trained, people know the signs, they recognize them early, they understand the reporting mechanisms. It may be that you don't have to do a lot, but it may be that things are not what you would like them to be. Data can tell you that. So taking a look at how many people had to be sent out for sepsis, you know, and really being able to determine whether your facility is where you want it to be or whether you want to see some improvements. Next slide. Next slide. The possibility of using electronic prompts is something you should think about. Next slide. Next slide. And lastly, ensuring that patient and family caregivers are enlisted in this effort to spot signs of sepsis early. Next slide. Keep going. Okay.
My mother, a 20-year breast cancer survivor, she dies of a disease that we never even heard of.
Septic shock, sepsis, and she was like, how do you spell it? I said, I don't know.
Really, does it affect that many people? Then why haven't I heard of it?
My mother, Mama, she had plans of being a gospel singer. Clot in her femoral artery. She got through that surgery, but she started complaining of a lot of weakness, couldn't catch her breath. When I heard the word sepsis, I didn't understand it.
I remember that I went to bed, woke up to find the EMTs in my room. My doctor friend called the hospital and said, look, unless somebody's coding, there's no one in there as sick as this man is right now. Get a doctor in there. In the next few hours, I had one shutdown after another, all of my organs, lungs, kidneys, eventually a heart attack. My toes were blackened and gangrenous. It was very unclear as to whether I would survive.
It was Halloween. He was up crying and crying. I took his temperature, 102.3, and his color was gray. His lips, his everything was gray, and he was not responding. We got to the hospital. He got swelled up, so he was huge. And one of the doctors said, we don't know if you'll be able to take him home. I'd been waiting for him for all these months, and I've only had him 3 weeks. He's mine. I wish I would have asked more, but I felt like I was supposed to know as a mother.
I didn't understand that any infection could result in a toxic response that is known as sepsis. It started when I went to the dentist and had some dental work. Following that, I developed an infection and then septic shock.
I can't even describe to you the horror of seeing her die of sepsis. The body swelling up twice its size, fingers turning black, having to be intubated. It looked like someone took a shotgun and shot her in the leg. That's what it looked like.
For me, this could have a very different ending. And it's why I share my survivor story.
And the nurse, her name was Annie, and she says, "Are you ready to hold him?" And I said, "Oh my God, yes." She put him in my arms. And she says, "He's gonna be okay." I thought maybe if I share my story, somebody will learn from it.
Mama's gone, but maybe somebody else can be saved.
Sydney, if you could stop sharing, we want to start the Q&A session. So, questions for us?
If you have any questions, you can type them into the chat. I'll read it. Or if you want to unmute and ask your questions, that would be fine as well.
Comments? So was this useful?
Yes, it was.
Highly informative. Thank you.
Very useful.
So let me ask a couple of questions of you. Do you think that that your staff and others, your colleagues at your institutions, are well prepared enough based on what you've been learning today and last Wednesday? Or are there some things that you would like to change once you go back?
We are talking.
I think for us, this is Rachel from Fairland. For us, it's basically, for giving more empowerment by educating our nurses, because with the pandemic, we have so many brand new nurses, and it takes time to pick up on those, with experience. So it's just more of education.
Thank you for that comment. I thought I saw someone else who was about to speak.
Yeah, this is Olivia from Hebrew Home. I think we got a lot, and we will have to meet and discuss some of the things we heard from the group sessions. And also, when you send us the package, you said you were going to send us tools. So we'll look at them and evaluate, compare with what we have, and see what we need to revise.
Okay. Anyone else have a comment or a reflection about what they might be thinking about doing in the future?
Dr. Phoenix, I think there's some comments in the chat section.
Okay.
that you might want to read.
Okay. A couple of folks thanking us for the training and saying that it was useful and informative. Someone saying that we're going to review the communication and use the alerts that are available. Another person said they want to be more proactive and recognizing the signs of sepsis early by empowering our nurses and ancillary staff and continuing to educate our staff. Another person said we'll need frequent education and re-education to empower SNF nurses. And the last comment I see is we will review current tools and the frequency with which we educate staff about sepsis. So I think we should finish up by reviewing the pretest. I promised you that. So Sydney, can you pull up the presentation again? We've got the pretest questions in there. Okay, so question 1, can everyone see this?
Yes.
I hope so. Okay, great. So question 1 was, what factors are associated with higher mortality for sepsis? The choices were old age, cancer, previous sepsis, and all of the above, and the answer is all of the above. Next question. So question 2 was, which of the following laboratory studies normally done to confirm or rule out sepsis can be used as a criterion to decide whether to transfer to an acute care facility? The choices were lactate, creatinine, white blood cell count, hemoglobin, or INR. And the answer is A, lactate. Again, the lactate level is a more specific indicator that there's many cells in the body that are not being properly oxygenated. And so the lactate levels will rise. A lactate above 2 warrants concern, above 4 would prompt transfer. Next slide. If you have a resident suspicious for sepsis who's being treated in the facility with fluids and antibiotics, and their mean arterial pressure drops below 65, what steps should you take? Document the vitals. B, prepare an SBAR. C, contact the nursing supervisor. D, notify the physician on call. E, all of the above. And the answer is all of the above. Next slide. A family member is visiting and reports that their loved one seems less lucid than at the last visit and won't eat. What steps should you take? A, document the report of a change in mental status. B, assess mental status and report the score to the nursing supervisor. C, wait until the shift changes and put it in your note. D is A and B, and the answer is A and B. And I apologize, I'm pretty sure I skipped question 5 when I was putting these slides together. So let me just read that to you if I have it. So question 5 is it important to provide training for family members and all staff, including those providing services like food service and physical and occupational therapy, so that they can recognize early signs of sepsis? And that was a yes, no question, and the answer was yes. So with that, I want to thank everyone for taking the time to participate in the training. As I said, we'll be providing you with a training manual that you can use to train others. But we'll also be providing you with a complete slide deck of the 2 days, the 2 training days. You'll probably get the slide deck pretty soon. And the training manual will come sometime during the month of May. So again, thanks so much to all of you. With that, the training is ended for today.
Thank you.
Thank you all.
Thank you.
Thank you so much.
Thank you. Thank you, Doctor. Thank you, Tammy.
Thank you.
Thank you.
We'll be sending out the email for it with the PowerPoints and the recording as well. And what
okay, that's what I want.
recording and the PowerPoints on our website for better use, but we'll send out all that information via email. And like Dr. Phoenix said, the training manual should be out sometime in May, but we'll continue communication via email. If you have any questions, anything that you think will be useful to add to the training manual, send me an email and we'll include that.